Right. So we left off looking at the three main intrinsic mechanisms here to regulate GFR. We talked about the myogenic regulation. This is the smooth muscle along the walls of the afferent arterioles. They can detect the pressure that is coming through these vessels toward the glomerulus, and then they can contract immediately as a response to that stretch. So that's your myogenic regulation. We also discussed the tubuloglomerular feedback. This has to do with the pressure and the amount of flow coming through the distal part of the tubule, the ascending limb of the loop of Henle. And so whenever there's an increased flow detected as it moves past these macula densa cells, they can also trigger through paracrine signals, which are cell-to-cell communicating signals, they can trigger the afferent arterioles to contract as well, the smooth muscle of those arterioles. And then the third mechanism was the mesangial cell contraction. So it also in response to that increase in flow, the mesangial cells themselves, which are in close contact with the glomerulus, right? We have some mesangial cells in between these capillaries, but also the extra mesangial cells that are located between the loop of Henle and the arteriole, they can also respond to contract in response to that increased flow. So three intrinsic mechanisms that we've described. And remember, intrinsic is anything inside the organ, inside the kidney. So these are all going to be considered local factors, things like paracrine signals, detecting the flow rate, the stretch response. These are all considered intrinsic, whereas the hormones, the sympathetic nervous system would be examples of extrinsic controls. All right, and then we looked at two of those examples here. So this is the myogenic response as well as the tubuloglomerular feedback response. Let's kind of go through what's happening here in these two examples. So remember, the overall goal is that whenever we have an increase in mean arterial pressure, especially within that 80 to 180 millimeters of mercury range, we want to be able to regulate the GFR as well. So an increase in mean arterial pressure should result in an increase in GFR. And so the way that we bring that about, the first one is myogenic regulation. So increase in pressure, that is first detected in terms of the stretch on the afferent arteriole. Their smooth muscle cells will detect that stretch, and in response, they constrict. That increases resistance, and then that decreases our glomerular capillary pressure, right? Having more of that resistance. The other mechanism is that that increased pressure directly increases glomerular capillary pressure. All right. And so having a drop in that glomerular capillary pressure in terms of the myogenic response is what sort of corrects that initial change in a negative feedback loop. So now we have an increase in glomerular capillary pressure in the face of the initial response, which was to decrease that pressure, right, because of the arterial response. And then that results in an increased GFR, which again is a protective mechanism in the face of increased pressure. And the other example, the tubular glomerular feedback, similar response that triggers this increased pressure detected by the glomerular capillaries. And then that results in that pressure being detected as increased flow by the macula densa cells. So whenever there's an increased GFR, there's more flow coming through the tubules, especially the ascending limb of the loop of Henle. That is detected by the macula densa cells as an increased flow rate. And then the resulting response through paracrine signals is to constrict the afferent arterioles and those glomerular capillaries and increase the resistance, which is a negative feedback response to shut that off. Okay. So two different mechanisms to increase our GFR in response to increased mean arterial pressure. One has to do with the arteriole, the smooth muscle cells of the afferent arteriole. The other has to do with the macula densa and their paracrine signals as a response. And just reiterating this graph, this is what we're trying to maintain. We want to maintain a constant GFR in the face of a mean arterial pressure change. But this only happens between 80 to 180. If our mean arterial pressure drops below 180, our GFR will drop as well. If our mean arterial pressure goes above 180, our GFR will rise as well. And so those mechanisms that we describe are how we bring about that regulation in the face of the mean arterial pressure change. And then to think about the extrinsic control, so those are intrinsic mechanisms. We also have extrinsic controls as well. So a decrease in blood pressure can directly decrease filtration through the intrinsic mechanisms, but it can indirectly decrease our GFR through other mechanisms as well, like the nervous system, the sympathetic nervous system, for example, which can bring about that response. So let's look at that example. And so the trigger here is going to be a scenario of hemorrhaging or sweating. Severe dehydration can be another example of this. But the overall change is that we have a drop in blood volume. That drop in blood volume causes a decrease in venous pressure. Remember, our veins hold a lot of the volume in our circulatory system. And so that decrease in venous pressure will be one of the first places that we detect an overall drop in blood volume. That results in two things. One, a drop in the venous return going back to the right side of the heart, which automatically affects how much blood we can fill, therefore, how much we can eject. So cardiac output will also decrease as a response. And then mean arterial pressure, which is our perfusion pressure essentially, will decrease because of a decrease in cardiac output. And so that triggers directly the baroreceptor response. Remember, baroreceptors are our mechanical pressure receptors. They are found in our veins, but also mainly in our carotids. They can detect the amount of pressure exerted in the blood that is passing in some of those central arteries like the carotids. And so they detect that drop, which triggers automatically the sympathetic nervous system response. And so when we engage the sympathetic nervous system, that is going to increase our vasoconstriction to the afferent and efferent arterioles that are forming the glomerulus, which increases our vascular resistance in the kidneys, right? As we clamp down on those vessels, right? As the smooth muscle contracts, that makes the lumen smaller, that increases the vascular resistance. And so that is the response that decreases the GFR, right? So the overall trigger for the change was a drop in mean arterial pressure, and we want to imagine this to be lower than 80. And so the response that we want to see is a drop in GFR as a response to that drop in mean arterial pressure. So that ends up dropping the urine flow, and that decreases fluid loss. Both of those things will be a negative feedback response onto the initial trigger, which is a drop in blood volume. Now we can preserve fluid loss in the kidneys, decrease how much urine is being produced, and we can sort of keep that urine to maintain our mean arterial pressure in the face of things like hemorrhaging, sweating, dehydration, which is the original example. All right. And then our other sort of changes that happen, the intermediate changes here, like a raise in mean arterial pressure, a raise in total peripheral resistance because of the sympathetic response onto the kidneys, that in and of itself can also be a negative feedback loop onto the drop in mean arterial pressure, right? That can sort of reverse that initial mean arterial pressure decrease. All right, let's keep going. Let's actually take a pause here, look at a few practice questions. And I'm going to give you 3 minutes to look at these questions. Please try to write your response down. Okay, now we're going to get into the mechanisms of reabsorption. So far we've talked about the filtration process. We've talked about the glomerulus. We've talked about the Bowman's capsule and how we initially move that plasma across the filtration membrane in order to create our initial filtrate. We're going to move on to discuss what happens as we begin to fine-tune that filtrate as it moves through the tubule, right? As it moves beyond the Bowman's capsule and into the rest of the tubules of our renal corpuscle. We want to remind ourselves of the peritubular capillaries. This is how we can move um, substances, molecules that were filtered that we would like to reclaim, water, sodium, glucose, those things that are crucial to the body, those can be reclaimed via the peritubular capillaries. The efferent arterioles continue on into these winding capillaries that wrap around the other parts of the tubule to reabsorb those filtrates, molecules that need to be reclaimed. So this is going to happen mostly in the proximal tubules, and this is unregulated for the most part. So it just kind of happens until our carriers are maximized or the carriers are saturated, and it's not really as regulated as things like our GFR and other substances that will be reabsorbed in the distal part of the tubule. So here's just an overview, nothing to memorize here, but just to understand the proportion of certain substances that are reabsorbed, things like water. So we filter about 180 liters of water per day, and we reabsorb most of that. 99.2% of that is reabsorbed, especially in the face of things like dehydration, loss of blood volume, bleeding out. We need to reclaim a lot of that water just to maintain our mean arterial pressure, our blood pressure. Glucose is also freely filtered, 800 millimoles per day, and all of that is reabsorbed. We need to have all of our glucose filtered. It's small enough to get through the filtration membrane, but it should not be in our urine. We need to reclaim all of the glucose. And so in states like diabetes mellitus, we can see spilling of glucose into the urine because there's just so much in the blood that it maximizes our carriers. Remember, glucose moves by facilitated diffusion, so it needs carriers or transporters. When those become saturated, we simply start spilling urine, glucose into the urine, which can be detected, with a dipstick test. So that can be one of the first signs of diabetes, spilling that glucose because of the saturation. But in the normal healthy physiology, all of our glucose should be reabsorbed. And then other ions like sodium, potassium, calcium chloride, bicarbonate, those are for the most part freely reabsorbed. And more than 80, 90% of those substances are reabsorbed. Urea is also reabsorbed. About 50% of the urea that's filtered is reabsorbed, and about 50% should end up in the urine. Let's look